Good afternoon, dear colleague. I would like to thank OMICS group for having invited me to present you this paper. Sorry. No, there's a small problem. So I will talk to you today about the sacroiliac joint biomechanics and its potential clinical implication. Here is the structure of my presentation. In the first chapter, we'll talk about the singular. In the second chapter, about the sacroiliac joint biomechanics. In the third chapter, about the sacroiliac joint pain patterns. And in the last chapter, about the potential clinical implication. The sacroiliac joint anatomical complex is the largest axial joint in the body with an average surface area from 17.5 square centimeter. It's surrounded by ligaments and muscles and receives innervation from L5 to S4. It's capable of producing pain. Diagnosis and, according to Zelle et al., diagnosis and treatment of sacroiliac joint dysfunction are poorly defined in the literature. Significant extra-articular pain exists. Intra-articular diagnostic blocks underestimate the prevalence of sacroiliac region pain. SIJ pain is a common cause of axial low back pain, affecting between 10 and 25% of people. It's the fourth common cause of low back pain and pelvic pain. It represents a prevalence from 6 to 13% source of low back pain, pelvis or referred lower extremity pain. SIJ and posterior SIJ ligaments are source of posterior pelvic pain. 10 million in USA have osteoporosis. 34 million have low bone density, which increase the risk for fractures. 1 in 2 women and 1 in 4 men older than 50 have osteoporosis-related fracture during their lifetime. SIJ bridging is a male phenomenon, but not age-related, but not ethnicity. It is ethnicity independent. SIJ surface area is greater in males than females, which increase the biomechanical loading in males. According to European guidelines, pelvic girdle pain is specific from low back pain. The myofascial hypertonicity hypothesis linked the biomechanically characteristics of spinal and SIJ lesions observed in ankylosing spondylitis. Bony pelvis widens more than 20 millimeters over the course time of a lifetime. Manual therapists, for example, physical therapists, chiropractors, and osteopaths, administer various procedures when they're treating SIJ dysfunction. These treatments are based on the belief that a small range of movements exists in the SIJ. Why is it the least understood joint? Very difficult to scientifically analyze. Reliable test needs to be 3-dimensional. Multiple titanium spheres implanted into the bones or rigidly fixed external devices. Testing in vivo, standing, prone, supine, and hip movements. Now some words about the terminology of the biomechanics in the second chapter. SIJ dysfunction is defined by pain in or around the region of SIJ. It's also defined by hypo or hypermobility. From Hippocrates till Vesalius, they defined no movement in SIJ other than during pregnancy and birth. Gynecologists were the first to be interested in this joint, followed later by orthopedic physicians. Now you get a representation of the years and the sacroiliac joints. From the birth till 20 years, the articular surfaces are smooth, gliding, wonderful. Imagine that when you were 20, how beautiful. Between 20 and 50, there are the beginning of interlocking irregularities. Over 50, it becomes hypermobility. And over 80s, you have presence of osteophytic and it is immobile. This could explain, if you allowed, when you see older patient or a person walking, so why? Not because they are scared to walk, but because their pelvis is not free of movement anymore. Because when you move, your two ilium should be walking so, and your sacrum move between, that allows a movement correctly. And that explain could be one of the explanations why the older people walk so not because one of the explanation could be also a neurological explanation. They walk so because their pelvis is not anymore free. But I have patients over 80s, they can dance lambada, whatever. It exists also. So now about the sacroiliac joint structure. It's a diarthrodial joint with two bony surfaces, sacrum and ilium, 1 to 2 millimeter wide. The joint surfaces are lined with hyaline cartilage, and the iliac cartilage seems thinner and more fibrocartilaginous than that of the sacrum side. The superior third of hyaline iliac cartilage is strongly attached to the surrounding stabilizing ligaments, forming a wide margins of fibrocartilage. The inferior third of the joint along the iliac bone has some histologic characteristics of a synovial joint. Hyaline cartilage of sacral side moves against fibrocartilage on the iliac side. Numerous ridges and depression indicating its function for stability more than motion. SIJ articular surfaces are not smooth but have interdigiting symmetrical grooves and ridges. SIJs act as important stress relievers, enforce motion, relationships between trunk and lower limb. The ligaments is a strong passive viscoelastic ligamentous system surrounded by an extensive network of ligaments and fascia. The primary function of the ligamentous system is to bolster stability while allowing for adequate range of movement in multiple planes of movement. The ligaments include the sacrotuberous ligaments, the interosseous ligaments, the sacrospinous ligaments, and the long dorsal ligament. Here you have some views about it, a front view, the interosseous ligament, and posterior view. I'm sorry for the bad view. On the PC it's better. Now, a sensory motor control and biomechanical aspects of ligaments as may be contributory to neuromuscular disorders. That's a project of 25 years, presents the following 8 hypotheses. The ligaments are the major sensory organs which can deal kinesthetic and proprioceptive data. Excitatory and inhibitory reflex arcs recruit or de-recruit gives a joint stability to the muscle action. There is a synergy of ligaments and muscle action which allowed a joint stability. Viscoelastic properties and classical responses decreases effectiveness as joint and exposes the joint to injury. Long-term exposure to static or cyclic loads or movements can induce repetitive injuries. Continued exposure to static or cyclic load induce chronic inflammation on chronic neuromuscular disorder, which induce a cumulative trauma disorder. Knowledge of basic and applied research on the sensory motor function of ligaments as infrastructure for translational research. And knowledge of basic and applied research to induce new therapeutics modalities. Here is a broader model from Langevin and Sherman, which have an hypothesis that for the chronic low back pain, which has a components of sensory motor and a tissue model. There are 35 muscles attached directly to the sacrum or innominate. 5 major muscles groups associated with the lumbosacral structures are the multifidus divided in 5 bands, the latissimus dorsi, the gluteus maximus, biceps femoris, and the piriformis. Now there are 2 muscle slings, the posterior oblique sling which is composed from the gluteus maximus, the biceps femoris, the fascia thoraco-lumbalis, and anterior oblique thing is composed from the piriformis muscles, the inguinal ligaments, the linea alba, the external oblique muscles, the transversus abdominis muscles, and the rectus abdominis muscles. The innervation. For Solonen, the SIJ is innervated by L4 to S1 nerve roots. For Bradley, the SIJ received the supply from dorsal rami L5, S1, and S3. For Ikeda, it received the supply from a fifth lumbar nerve. Grobe al, for Grobe al, it is exclusively innervated by S1 to S4 dorsal rami. For Villa et al, it is the dorsal sacral plexus, S1 to S3. And various studies demonstrated the close relationships between SIJ capsule and adjacent neural structure. As you can see, it's the complexity of the innervation. Now I give some words about the biomechanics. Some definition. The SIJ is designed primarily for stability, rotating and translating along 3 axes, motion about the X, Y, and Z axis. These axes constitute a Cartesian or coordinate system and used by investigators to account for the 3D sacral motion at SIJ in reference to a fixed pelvis with occasional alteration of X and Z axes. Here are some models, but I show you these models to show you that the human body cannot be reduced to only axis. It's only an didactic model for we clinician to imagine the joint. Jacob and Kirchner inserted wires into the iliac bones of the sacrum and used RSA, is the radiostereophotogrammatic analysis to investigate the mobility of the SIJ. They measured motion and amplitude around an helical axis with 3 rotation components. Schmidt et al. Analyzed the SIJ and pelvic in neutral and straddle position. The iliac position did not fit not always with expected movement in function of the hip joint position. That means if you do such movement, you would believe that the pelvis is going forward, the SIJ, but according to the image, it was not the case. Because that's mechanically, and we don't take into account the tissue, the muscles which can retain pull on the structure. Bussier used also the RSA to investigate the SIJ motion in prone position with knees in flexion. Now some image of the helical axis where Jacob and Kissing were told to be. In summary, the range of motion of the SIJ is between 2 and 4 degrees. There is no significant difference between women and men. For Thalberg et al., they used RSA and they found no difference before and after manipulation. All studies detected helical oblique axis indicating the existence of a 3-dimensional movement in the SIJ. The major movement component is in the sagittal plane, which means that the axis should be in the area of the sacroiliac joint ligaments and iliac tuberosities. No common axis exists for both joints. There is limited movement in the SIJ due to the multifidus muscles limiting the nutation. It's anterior flexion of the sacrum. The transfer load through the pelvis depends on an optimal function of bones, joints, and ligaments, an optimal function of muscles and fascia, and an appropriate function of a neural function. Now about the sacroiliac joints pain patterns. That's for your clinician, would be more interesting than the biomechanics before that I told you. That's a myotomal pain referral region from muscle trigger points. You see in A, a quadratus lumbarum. That shows you, wait a minute. It shows you here, if the muscles goes here from the 11, 12 ribs down to the iliac crest, here. If the muscles is tensed, you can have tension in the bottom, in the leg also, only. And the second is the piriformis, going from the sacrum to the hip, crossing the sciatic nerves. It gives the same image of disc herniation. And the third image is from the psoas iliac, iliopsoas. You can have pain here in the inguinal part or behind in the back. And the last is the rotatorius and multifidus muscles. Can give you back pain or only here in front of the abdomen. I had a patient who had only pain on this part. It was emitting the same pain like a zona, but her GPs did her some injection because he thought it would be a zona, but she had not the skin sign of a zona. And when she came to me, I treated her with her back fascia on the muscles and manipulating. And after my treatment, she did not anymore have pain in front of the abdomen. Now, about sclerodermal pain referral regions from the ligaments. The iliolumbar ligament. You see here in A, that's the scientific anatomical drawing. And I will show you now what I found in my office by patients having dysfunction of L5 vertebra, for example. And when treating this L5 vertebra, they didn't have any more pain in the iliolumbar ligament. And I will show you why could be that the reason in a slide later. Now on B, you will have the sacrotuberous spinous and sacrotuberous ligaments. You have here where the pain reported. And the last, if you have all your sacroiliac ligaments under tension, you have pain behind in the sacroiliac joint region and the lower part of the low back, and all along all the leg behind. It's the same area as L5 disc herniation. That could be one explanation. Here you have a front view of a 54-year-old woman where we removed all the organs visceral, and here you have the iliolumbar ligament, which doing a head with his lower part, and here down coming the nerve roots, the ventral nerve roots of L5, which could be one explanation of my findings. But maybe I'm wrong. And that's the thoraco-lumbar fascia with all its connection to an ischial tuberosity, sacrotuberal ligament. Now, some word about the potential clinical implication. The differential diagnosis in SIJ pain generated in SIJ or surrounding structure can be present as low back pain, leg pain, sacral pain, pelvic pain, or gluteal pain. New aspects of SIJ pain treatment have to be taken in consideration, as well as biomechanics of SIJ. Clinical manual movement test unreliable for SIJ. Recent research reveals that the pelvis does not stop expanding after skeletal maturation and cessation of longitudinal growth. This is thought to be an adaptive response to compensate a loss of strength produced by endocortical bone loss. Altered motor function of the deep abdominal muscles in patients with pelvic girdle pain leads to insufficient bracing of the pelvis. Chronic spinal overloading can induce sacroiliac joint microdamage and repair pathway, and synovitis erosion and later stages of enchondral ankylosing. So the importance to practicing sports as I said this morning on the different conferences. I would add to that also to pay attention about the structures. The cartilage, which was a good team debated before me. According to McGrath, first, where is the pain generator in the absence of discernible pathology? Second, do SIJ pain provocation tests achieve what they purport to achieve? Third, do physical tests stress the joint to the exclusion of all other potential generators? Fourth, are all pain generators in the region identified? And finally, fifth, is intra-articular injection an effective gold standard for the elimination of putative SIJ pain? As you can see, a lot of questions remain. Thank you for your attention.
My name is Antonio Veloso from the University of Lisbon, and I actually work in biomechanics.
Yeah.
And the issue that you present, like you mentioned an helical axis, and you should know, I don't know if it's clear for you, that an helical axis is a mechanical way to define.
Sorry.
The helical axis you talked about, okay, doesn't have anatomical meaning unless you consider the projection of an helical axis against the plane.
Yeah.
And probably is what you mentioned, but doesn't have any anatomical meaning. It's a way to define an axis with a convention that is easier to explain. But you propose us having doesn't mean that it's 3D. You know, it's a complete different way to define rotation of rigid body.
I agree with you.
In relation to another, to two joints, in fact, but it doesn't have any anatomical meaning.
No.
That's why it's difficult to understand.
Yeah.
But the issue that I would like to point it out is that you mentioned, for instance, problems in L5 or some of the vertebral roots, and you are trying to address a lot of problem related or pain to the joint that has the last movement, even in the movement that you perform. Even if you have a small, you will have like a continuum. You have rigid bodies, then connection between rigid bodies maintained by viscoelastic structures. You can have, of course, complex mechanical representation of that, but you are addressing a lot of responsibility to a joint that has a very small movement, while you have joints that have huge movement that probably will be.
No, I agree with you. Okay. Of course, it's simplest. But it's only an overview of the structure. It can be. You have to do a differential diagnosis to see what is the main responsible of the pain. It's part of a solution, but it's not a solution. I agree totally with you. It's a good remark.